Hello and welcome back to the Pulse Check podcast. I am Mandy.
I'm Hee.
Hey, and we have an awesome guest today talking about the hidden world of hospice nursing. That's right. We're birth workers. You always hear Hee and Mandy talking about the world of labor and birth and L&D, but we have Nurse Allie today to dive into hospice nursing. Hey, Nurse Allie.
Hi, how are y'all? Y'all. Yeah, we're going from the start of life to the end of life.
That's
today.
Right. That's right. And first, can I just ask, how did you get into hospice nursing?
So when I was in nursing school, I ended up having a lot of hospice patients. And I would spend a lot of time with the hospice nurses when they came in to check on my patients. And I was like, this is amazing. Like, I think it's the greatest thing. And I watched my Volvo, my grandmother, she didn't have any real advanced directives put in place. She had a healthcare proxy and all that stuff, but her wishes at end of life were not known. So when she had her second stroke, they did the full workup on her. And the last time I saw her she was on a ventilator. And, when you see that pumping of the chest, I'm like, there has to be a better way than this. We could have put her on hospice a long time ago, and she would have had an easier transition out of this world. She probably would have qualified for hospice, a little while ago. And maybe this would have been a little bit easier of a transition into, the next life. Mm-hmm. So it's kind of things like that. Like that image is still, I don't know how ICU nurses do it, because she was in her 80s at the time too. So it's not like to me, that's not old, because I see people living so much longer, like another decade. But yeah, I know I'm like, and these were our World War II people, they weren't really, things weren't as regulated. And they were like, our World War II vets got pumped full of like amphetamines going into war. And they're like, and back in my day at like 100, telling me all these stories like they were yesterday. I'm like, okay.
So your early nurse part of your early career, you saw something that needed to be different or something that didn't really sit right with you.
Right.
And did you start in hospice right out of school?
I didn't. So normally across the board, hospitals look for BSN nurses. I'm like, I'm not one of those things. I'm like, I'm working on that now. Mm-hmm. But back then I was not. And in hospice, you don't need to have a BSN really. If you want to do education, it's good to have your BSN. That's what they want for our nurse educators in hospice. But so your options are pretty much like two things, like long-term care, or I could go work in a prison. Mm-hmm. My gut was telling me from seeing my sister working in long-term care when she first graduated with her ADN degree. I'm like, yeah, that doesn't seem safe. I'm like, I feel safer with my license in a prison than I do in long-term care these days, because their ratios are they don't care. I shouldn't say they don't care, but the nurses care.
Yeah.
The ratios are not appropriate.
It feels like they don't care.
So I was like, you know what, I'll go there. It's like a little mini ER almost, but you get a lot of med knowledge and deal with a lot of chronic issues. It's like a smorgasbord of things.
Yeah.
And it's a different environment. And so when I got in there, I was just, after about 6 months, I think I started applying to hospices, smaller ones, because I knew like the larger ones wanted a lot more experience. And so I basically just kept bothering them. And about 2 years into working at the prison, I got the go ahead, like, we're going to hire you. And I started out originally part-time because that's what they had. I was like, I'm going to take whatever they can give me. Yeah. And that's how awesome. I always recommend when people ask me, like, how do you get started in hospice? I'm like, well, you have to look at what they're asking for experience. But I'm like, if you really want, start out per diem, part-time, maybe at a smaller hospice where you can get a little more hands-on, one-on-one. It's a lot easier to keep track of people. Now I work for a very large hospice, which I'm thankful for because we have a lot more tools in our basket. Mm-hmm. But I'm really thankful that I started at a smaller one to kind of get my ground, because hospice is different. Our charting is different. Goals are different. Yeah. Charting is a lot. It's a lot of charting. Where we go provide care is different. Uh-huh.
That's helpful, I think, for new nurses and nurses wanting to make a transition. They're like, oh, it's a whole nother world. How do I even do that? But you're saying be persistent, and just like any other nursing job, go see what it's required. Get your foot in.
Sometimes if people are like, I'm not sure about it, per diem might be a good place to start because you only have to do you get the training and the base training, and then you only have to pick up one shift. So we've had nurses do that and they decided, what, this is not for me. It's too much, or I experienced death recently and I can't do this. And it's understandable to kind of figure out what you can handle. And that's okay to say, what, this is not for me. It happens. So, always try to do what you can, and know there's some hospice agencies that do have nurse residency programs for new grads, which is huge, which is what I would like to develop more across the country, because that's what we need. Because I feel like in nursing school, you get like a blurb about it in med surg and then it's gone. Like I remember reading like a page or so, and I know I hear from a lot of BSN, I think it's more so BSN programs, but they might do like 1 week at a hospice house. But like hospice houses are different than actual hospice, like home hospice, where we go to long-term care, ALFs, we go to people's homes, we go to group homes. When we send patients to a hospice house, it's for symptom management, usually, or respite care. Or if your family's really well off, you can have private pay and be there for your entire stay.
Wow.
But wow. I'm like,
wow,
that's not, if I could choose, I would also live in the hospice house because they have great coffee machines. The best. These are like, I think it costs like $1,200 for this coffee machine. It makes anything you want. And they have quartz countertops everywhere. Yeah.
Well, if your house is bougie and you feel comfortable in your house, then it's kind of like the same. But if
I feel
not,
like it's more
it's
organized versus like when you're out in the field, it's chaos. Like I always compare it. The hospital is almost a controlled environment, versus we're bringing ourselves into, controlled in some way. Like you have there's places to put things and there's places that things go, versus we're working out of the trunks of our cars. And like our wow or cow is like our lap in our car, you know what I mean? Or like it could be our patient's pile of books in the corner.
Right. What a great visual though, because I was thinking of myself as the patient, and I would think, well, if my house was bougie and I was comfortable and bougie, I would just stay in my house. Or if my house wasn't so bougie because I'm old and, not able to do all the things that I was able to do, and the people that I hire aren't doing it right, I'd love to go to a bougie house where, they can manage my care and I can be taken care of. But for the nurse, the hospital part, the like hospice house is the controlled area, and the home feels less control for the nurse.
Because like, imagine, I think Nurse Penny, she's another hospice nurse to definitely follow. And she did one TikTok of trying to put, like, this happens a lot, trying to put a Foley catheter in. Sterile, right?
Sterile.
It has to be sterile. Imagine doing that on a recliner or a non-hospital bed. Like I've been putting in Foleys on patients where I've had the daughters holding up the legs or a flashlight. And I can't move the bed. So you get out and your back is like cramped. I'm like, I did it, guys. I got it. Exactly.
I want to ask about your like self-care and your psych care and all of that. But I want to go back to your work environment. And that's what we kind of want to highlight. Well, part of what we want to highlight today is the difficulties, the struggles, the rewards, the gifts outside of the hospital, because as you just kind of mentioned, and I'm so curious about, I'm already imagining, I always imagine nurses like sitting on recliners, brown recliners with like brown or green carpet. I don't know if that was just my home health nursing school experience, but I feel like that's where you go.
There's a lot of recliners. They love their recliners. They love them. Like some of them we don't like, we encourage getting a hospital bed at a certain point because it does make care easier. And that's what we want to do. But like, if a patients want to stay in the recliner, I am not going to move like Joe from his recliner that he's loved for like the past 10 years. It's not going to happen.
No.
Right.
What are you going to do about that?
He would not be comfortable. And if anything, switching them to a new environment sometimes may make them more restless. They may not get but they might not. It's like, trying to teach somebody a new habit at the age of 80 or 70, especially when they're at that process of end of life. Why are we going to do that?
Yeah. You're not going to meet your goals. You're not going to be comfortable.
Yeah.
So you're saying what's so interesting to hear is your goals are different, which you mentioned, and your environment is different. How are you supported as a nurse to support, advocate for, and help your clients and your patients meet their goals when, like you already kind of like touched on, you're working out of your trunk, you're in an unstable environment or kind of like chaotic nurse world. There's no
It's
control,
not
so
like
it's
like Sim
unpredictable.
Man when you had the nice
Yeah.
table, open your gloves and stuff. Okay.
Look at
No,
the
yeah.
monitor. You might have monitors. I'm not quite sure what it looks like, but how are you supported? How are you able to do your job outside of the hospital or not able to do your job outside of the hospital?
So, I mean, it's kind of hard because we're alone. You know what I mean? It's us. So, like when we walk in, we can't just like grab a nurse buddy and be like, "Hey, can you help me?" Sometimes we don't. We don't usually have our aides there either, or our patients don't have somebody that can help. So you have to be independent in assessment and kind of a MacGyver in a way to figure out how things can go. If maybe you don't have that supply that you need, can we wrap up a bandage or do a wound dressing per the orders as close as we can sometimes if wound care doesn't get delivered? Because we're the supply closet if the patient doesn't get the supply shipped to them while we're there. So we have a whole team kind of behind the scenes that
Mhm.
we have triage nurses who I know in my job, they're 24 hours. That's not in every single hospice. Like I said, I work for a larger one. So those girls help order, and guys, I usually talk to the girls. They help us order like DME, things like that. They'll help us figure out numbers for physicians that we're trying to reach. Because usually we keep in contact with the primary care or whomever they deem their primary care, just to keep everybody on the same page. We don't just kick them out because they're on hospice. We want everybody to be involved in the care. So we try to get orders from them that are like non-hospice related as much as we can. We also have our own pharmacists who do med reconciliations. They breeze over the med list of our patients every once in a while and upon admission to make sure that these medications are consistent with the goals of care and the patient's wishes. And then we also have music therapy, we have pet therapy, we have massage therapy, we have medical social workers, chaplains. So like we really, as a nurse, we do handle, like, we handle everything. We handle psych, social, emotional, physical side of everything, but we're lucky that I can delegate a lot to those, and they're all the team members are very well versed in there. We have NPs that do house visits. We have MDs who do house visits to our patients. I know.
I don't know if I knew that.
Yeah, it's not in, I don't know if it's in every hospice. I know in my previous one, if a patient was really struggling and we were like, we needed eyes on this person, the MD would do a visit, because sometimes, I mean, they have to also go with like the goals of care and also what they were taught as well. And sometimes they just need to put eyes on the patient to see and get a story from it. Cause like we can do our best, but sometimes I'm like, you know what? I don't know. Like we have a wound care nurse. She's actually a nurse practitioner who goes out and does home visits. If we're like, we're really stressed. Like people think hospice is just end of life. We're basically home health up until a person starts, transitioning. Like I said, our goals of care are different. We're not going to go for curative care anymore, but we will still continue with wound care. We'll treat acute things like UTIs, respiratory flare, whatever we have to do to get them comfortable. Because, a UTI is painful. Why are we going to and if antibiotics
fever,
right, if they're consistent with the goals of care, if the antibiotics are going to have more benefit, then we're going to put them on antibiotics. But we'll always have somebody around that can go lay eyes on the patient who has the power to prescribe, as I like to say. So I love our wound care nurse. So she goes out and she'll be like, yeah, this is what we're supposed to do.
So she can get you back on the track of change something. We need to update this.
Yeah. Cause like we only have so much knowledge as to also what is, of course, because money always comes into everything, what's on the roster of things that we can order and that hospice will pay for. So if hospice orders something like medication, wound care, supplies, hospice covers it, and so she's more in tune to like, oh, we can try this, things that we might not have thought of, because like, we're like, like a calcium silver alginate dressing, like Optifoam, is like $25 for the one. So like, we're very hesitant to order those things sometimes, but if she's like, yeah, let's do it, I'm like, Okay, order 25.
Oh, that's interesting.
I'll just
It,
call her and I'll be like, yo, this is what it looks like. She's like, yeah, we need that. I'm like, yes, we do need that. We do.
are your patients part of the planning for your goals? Because you talk about goals a lot, and it almost feels like everyone has to kind of make sure here's our primary, everyone get back on track. That feels
Yeah.
good to me, but is that reality?
Well, it depends on how cognitively aware our patients are,
Okay.
because we do have a lot of Alzheimer's, but say somebody's fully, they signed themselves onto hospice. Was their goal. Yeah. They are the main driver of everything that happens. If they say no, we'll educate them on to why we think this is the best course to go. But if they say no, that's it. We're going to
That's it.
go with whatever. Yeah, that's it. We're going to go with whatever makes them feel comfortable, and after, let's say they start actively dying, that's when they're not really of sound mind and body. That's when the healthcare proxy will most likely get activated and take over from there. But we'll stay in line. Our goals of care are completely made around the patient's wishes. So I don't know if you've ever heard of something called the 5 wishes before.
Mhm. It's been
Yeah.
a while.
So that's something that patients can use, and it is a legal document. So that, defines spiritual, personal, medical, and financial around what this person wants to have. And it's very specific, and it also the person can write in things that they want. And that's why I like it,
Mm.
because it's more personal versus like a most, or, something like that is just like check off boxes.
Mhm.
The 5 wishes is a lot more personal. So I think if people go over that with their loved ones before things take a turn,
Mhm.
and you express to your loved ones how much that means to you, that your wishes are carried out, it makes it easier for everybody. And also for your hospice team, because we always have to educate the families. Remember what the patient would have wanted.
Mm.
What were their wishes for this time in their life? And I have to say, most families respect their
Mhm.
loved one's wishes. I would have to say, they understand, because they've seen their loved one going through whatever disease process for a long time.
Mm.
And not only is the patient tired, but the family is, being a caregiver and even just being a family member of somebody who's had a chronic illness and now is terminal, they also know that deep down they want their loved one to be, they don't want them to suffer anymore. So I would have to say, every single plan of care, like I know care plans in nursing school, we all hated them and we're like, we're never going to use these again. Guess what? In hospice, we do.
Ah,
Yeah.
you just
A
lost all your
lot.
new nurses.
I know, but they're not like the ones
Right.
in nursing
They're
school.
not.
They're like
No.
pre kind of done. You check off a lot more boxes versus like writing out like a 32-page care plan.
Right.
It's not that. It's different. It is a pain in the butt sometimes, but I like about the care plans, you can also put orders in there so you don't have to type them somewhere else.
Mhm.
You know what I mean? And it's like a good snapshot of what is going on. And we'll put in their spiritual stuff, we'll put in
Mhm.
their personal stuff. Everything goes in the care plan. Ambulation, food, nutrition, all of it, everything.
I
So
don't
it's,
hate it. I actually don't hate it. I mean, I know the process is like super redundant and really hard to conceptualize when you're in nursing school. Also
yeah,
hard to conceptualize because you don't see it in real life, and like no one fucking reads
exactly.
them. They don't have any merit.
I mean, you're telling me that a professor is going to read a 132-page care plan for every single nursing student?
No, but in the hospital, who's reading my care plan?
I didn't like the charting in the hospital either. I was so confused. I was like, oh no.
I
Like,
don't, it does like if the care plan mattered, I think
that's
it's plan.
different when you're doing acute care, because even in the hospice house, we don't do the same notes that we would do out in the field. You know what I mean? It's different because we're managing an acute situation versus like a care plan. I feel is more long term, where
Yeah.
these are our goals of care until X time, versus you're trying to like manage a patient sometimes like by the
Ever change.
hour.
Yeah. Ever changing.
A
And
care plan doesn't really make sense
now I'm
because
going to go back
it's a
and
care
update
plan,
it.
not a a care snapshot. You know what I
Care
mean? It's supposed
situation.
yeah, it's supposed to go, it's a longevity thing. That's how I would describe it, because we're
Awesome.
looking for a long-term, like we don't always have to change every single care plan every time we
Yeah.
go over the care plans, or like we do INRs on patients
Mhm.
too. If they're on a blood thinner, obviously we still have to do that. I don't think people think of those things when they think of hospice.
Mhm.
They're just like, these people are on their deathbed. This is it. Morphine, go. Like, no,
That's
like,
exactly that's exactly what I'm like wondering, but
what
it's cool. You have
happens?
tons of skills that you're doing. You're still the detective. You're still like the
Yeah.
puzzle piece sorter
So
of,
much detective work, so
yeah,
much
that's
to figure out,
exciting.
because it depends on like how much, because when you go in, like say you go, we have special nurses, I should say they're very special because they do admissions only, bless their hearts, because admissions can be like 3 or 4 hours sometimes, and they go to the homes too. And imagine that, like being in a house, sometimes it smells like cigarette smoke, other times there's like cute dogs, and that can be a huge distraction. I love the dogs.
I'm thinking of like that transition that the family is doing alongside the admission of
Yeah.
like when I need to do something that I know I need to do, but I'm putting it off, and it's not the same as dying, actively dying or dying with dignity or coming up with a plan, but it's still like, oh shit, now, here we are.
Yeah,
This is
some of
real.
them, I think it's been a long time coming and they're more prepared for the next step. They're like, yeah, this is grandpa. He's 98 years old. Like, we understand. But like, then we get patients who are like our age
Mhm.
and they just got the word, there's nothing more that we can do. And so we have special clinicians who are child life specialists. So they deal with grandkids, children, and we do have pediatric patients. So they especially are prevalent in our pediatric hospice patients for the parents and the child themselves. So I would say those are a little bit harder because our older people have been living with chronic conditions for a long time. So the family's used to the back and forth from the home to this to that.
Mhm.
And, their goals of care, other than maybe possibly being a DNR. I mean, some of these people have been a DNR for a while. They've just literally come back. Like, we have people on hospice for like a year, 2 years sometimes, because they keep requalifying. Something keeps like requalifying me. Maybe they had a fall, they lost a little bit of weight, they had another UTI. Like, you can get requalified for hospice. We send in our nurse practitioners to see if our patients will still be considered qualified for hospice. And we have to do that per Medicare, Medicaid. That's part of the hospice benefit. So they will do as much digging as they can to keep people on, because it's just another toolbox these families have, another support system. And on average, patients in hospice live approximately 23 days past their prognosis because of the extra care that hospice provides, because it, like I said, it's psychosocial, emotional, spiritual, and physical. And that's huge. We have hospice aides going in 5 days a week to help people, and we have all those other support staff that I mentioned before. So for these families, it's like care in home that they've never, like, who gets a doctor's visit in home anymore in the
Mhm.
United States? At least not anybody. Our team is very much involved. You know what I mean? It's not like you're going to hear from our MDs in a month with results. We have them on phone, we text, we call. I'll call a million times. It's easier to get a hold of our MDs because they'll pick up every time. Versus like the primary, I might not hear from them until 2 business days later.
Tell
Go
us
ahead.
about how staffing impacts this. So if we're seeing a shortage and, staffing is already unsafe, what implications does this have on the quality of care if the care is so acute and so tedious and needing a lot of attention to detail that staffing shortage must collide somewhere with that? And I expect the
Yeah.
give is on the quality of care side.
So for us, I would say we will do whatever care we need to and be as thorough as we need to. We will just hold off on the charting.
Yep.
So we will chart on our breaks. We'll chart at home. I know. And I tell people, always chart as much as you can in the house, even if it's just little blurbs in your narrative. So you are not stuck charting until like 12 at night. And so, it's very important when you're also looking to a hospice agency, what is your caseload going to be? I feel most case managers feel comfortable 10 to 12. Do they all have more than that? Most likely. Yeah. And it's, we're spending about an hour at least sometimes with these patients, if not more, if they need to be comfortable. So like when we're short staffed, at least in my agency and my previous one, our clinical managers would go out and start doing visits. But we would still somehow have to put off some visits for the evening staff. Or like, you know, in nursing, we won't take a bathroom break or we won't eat or something. That was hard at the beginning of the panorama because of the fact that most places didn't want you using their public restrooms.
Yeah.
We're not really supposed to use bathrooms at people's houses, but I gave myself a kidney stone. I'm like, I am not doing this anymore. I can't do it. And like, especially like when you're sitting in your car and you're trying to like not pass out and you're like, I need to drink water, but I'm going to explode.
Oh my God. And like postpartum or pregnant or any other medical condition that requires you to be healthy and use your bladder and kidneys regularly.
Yeah. And it takes time out of our day to stop somewhere to go to the bathroom. If you have to park, get out of your car, go into the gas station, wherever you choose. And, you know, I'll pretend I'm looking at something and then I'll just go to the bathroom. Or, you know, grocery stores are a great place to go. But yeah, it does take a little bit of time too. And you're like, you have to bring in like you have to make sure your laptop is locked up securely in your car. And then you have to because we have work phones. So we're like bringing all of our crap, like these phones in, plus your personal phone. You're like, this is not fun. And, you know, going in with scrubs anywhere at that time was like, is like foreboding.
Yeah.
I'm like, I don't have a choice. I'm going to pee myself.
Oh my gosh.
So
No eating, no peeing.
So we try to eat when we drive, but I'm like, if I choke, I'm screwed. So like soft things like bananas, Slurpee yogurts, things like that. And so a lot of us will chart while we eat. So it's kind of, and that wasn't when the pandemic first started. I was like, I'm not even touching anything that goes into the home before. So I made my own little like hand washing system with using like a pump that is meant to pump water out of those like Poland Springs bottles that you have delivered to the house.
Yeah.
But I attached a hose to it so I can clip it to the side of my car with a magnet. And so I have my own little hand washing system because I will not eat if I don't get to wash my hands.
Yeah. Nurses are MacGyver. That's nuts.
The pump was like $10 on Amazon. In my link tree in the Amazon list.
Yes, of course we need to go there and get that pump.
I'm like, you know, and it's great for like anything too.
Yeah.
Like nowadays it does get a little chilly. So you want to warm it up. Like you want to fill it the morning of work. There's a lot of prep that goes on before work because we don't just show up and our stuff is there. We have to charge our laptops, charge our MiFi, which is our Wi-Fi. We have to charge our work phones and we have to get I'm like a police officer because my passenger seat is my office. You have to make sure you have everything you need for the day before you head out the door.
You don't just go in, clock out, and you're done. Where I always was like, that's such a benefit. I'm not like a teacher where teachers are expected to like get their stuff done on outside hours.
Before they go. Yeah. I don't because I try to work as many weekends and evenings. So like I don't do case managing because I have a little one and I'm in school now. I'm like, I can't take that on because it is, like you said, a lot of kind of behind the scenes work and a lot of follow up. I don't have the commitment for that, but I love working. I call the weekends, like it's like ER of hospice. We're just going from one place to the other as things kind of pop up. And then we also have routine visits going on in between the things that pop up. So it's madness, but the team is amazing. We just like, if they're like, we need you to go see this person now, we're going to take this other person off your list. I'm like, super awesome. I'll go. That's fine.
Nice. Yeah. Yeah.
And they're understanding. They're like, we understand you're only working. I'm going to work until this time today.
Yeah.
You know, so they're like, okay, so we'll give you this, and this patient. And I can be honest and say, I think that's too much for me for the day.
Can't get there and do those things.
I can't. I'm like driving wise in between patients, like you have to calculate it in. It's not going to work out if I need to really solve issues for patients. And like we have to call pharmacy. Then we have to chart that we called the pharmacy. And then we have to chart that we contacted the family or the patient and educated them when the meds are going to show up and what's the medication and And then we have to send emails to the case managers and the clinical managers about everything that we did at the visit. So it's a lot of, and then before we clock out, we have to put our mileage in, of course. And then we have to find, and hopefully we have good reception, because if you don't have good reception, you have to drive to a spot that you do have good reception. So like, and when we put narcotics in, we have to finish our note, our visit, and then sync the computer. We're not on a live network. If you're on a live network, it's a little bit different, but we're not. So you have to sync and then get everything, and then triage can send the narc prescription to the physician to get signed, then send it to the pharmacy to get filled. And then you have to chart that you did all that.
Syncing takes time. All of that takes extra time.
It does. And like, I know our patients would be like, there's no reception here. I'm like, yay, I'm going to have to drive somewhere and find somewhere to park. And like, if you're parking in a parking lot for a while with your laptop charting, you look suspicious.
Yeah. My mother-in-law would do that. She talks about home health PT, and she's like, the number of times a cop comes up to me and I'm like, I'm here because I felt unsafe everywhere else. I'm safe.
I thought we were good here. I know, like, note to everybody, if you join home health or hospice, don't park in front of a bank. That's a bad place to be.
Sus. It's nice and quiet.
I did that once. It was hot. It was shady. Smaller town. So, you know, the cops are just around.
Yeah.
Can I help you?
And they're knocking on your window and you're like, no, I'm alone in the car working. I'm safe.
Yeah.
I'm
like,
open up
no,
the
I
window.
don't want your number. No. Oh, that's not why you came. I'm so sorry.
We're okay. You're working.
I'm like, backtracking. How embarrassing. Like, we get the tap, tap, tap on the window.
Yeah.
Ma'am, why have you been here for so long? Because I need to chart. I guess you could use the fire department or the police station because they're public entities legally.
Like a library. Okay.
Yeah, a library is another good spot. Super quiet though. So if you have to have the farts, don't go into a library.
Good.
Not a good place
Good
for
call.
that.
No, good call.
Yeah. Do it in
Well,
the fire station because you can just blame it on the firefighters.
That's right.
I know in the hospital though, you guys can have a specific pooping bathroom. I've heard that there's specific bathrooms.
It's right across from the manager's office.
That's a great idea.
So you don't actually have to say, where's your other bathroom? You can just say, where's your manager's office? And then you go find the bathroom around there. And that's the shitter.
That's a good idea.
I haven't even worked for many places. I just know that's pretty universal.
I only go to the hospitals every once in a while because if we send a patient to the ER, sometimes we'll go check on them or we have to go sign revocation paperwork. And we have to like, I'm like, if anything, this person just got sent out to the ER and now we're going to the, be like, hey, can you sign this paper for us so we can take you off of hospice because of Medicaid? You know what I mean? They don't want to bill hospice another day when this patient's admitted to the hospital. But if they get admitted, we can just readmit them when they get discharged. So I'm like, don't be scared. You can just come back on. Don't be scared. We'll welcome you back. We're still here whenever you're ready.
So much rigmarole. Well, at the end, I want to ask just a few like quick fire questions that I still have left for you. Is that all right, Allie?
Yeah.
Okay. Couple quick fires and then we'll tell everyone your handles and we'll also have it all linked down below so everyone can follow your work. First question was one that I alluded to earlier. So I really like hearing all of the ins and outs of the job. And I think we don't get to hear a lot of this. Social media is great for that, but also it's really nice to hear from a nurse who's like living it and doing it, what it's like for hospice nursing, what other nursing skills you get to use. Some of the best parts of nursing, I feel like are coming up when you're talking about your job. What do you do in your life? You already said you have boundaries around your hours and boundaries around your time.
It's huge.
And having other priorities in your life that are kind of max, like you said, your children, your education, you've prioritized over your work, family, whatever that looks like, your team, right? You know, your patients, like you prioritize your patients and you prioritize your team. But when you prioritize other things in your life, you can be like, okay, I can be here for this amount of time. And then my other priorities are here. What do you do to help with your self-care, with your own body, with your own trauma, with your own feelings, emotions, psych, the toll that it takes physically on your body, because you're saying you're sometimes alone. And there's a level of like awareness, always being aware, always being safe.
But I feel like our families, I feel like home health is like I shouldn't say it's way different, but like, I feel like they go anywhere. You know what I mean? Versus like hospice is kind of like
Right.
a little more selective. They will go anywhere. Like I've never once run into bed bugs. Not once.
Okay. Okay.
Knock on wood, because now it's going to happen. But like our families are always like, we always have a pretty, good admission process. And we have a bunch of people who go in before like the actual case managers and everyone else starts to kind of trickle in. So we kind of vet the whole thing. We're more aware of our surroundings. Like, this is what you're going to experience. Family has a large dog. Family has cat that likes to hiss at you, or, they're in this area, park here. Sometimes the parking isn't always obvious, which gets me. I'm like, it saves so much time if people can just tell you this is where you should be parking. You know what I mean? You have to figure out your route as well during the day. And that's another thing, because you can call your first 4 patients, everybody's on board with the time. And the last one is like, nope, that doesn't work for me.
Mm.
And so you have to figure out how to rearrange everybody else that you just set up visit times for. So, self-care for me looks a lot like boundaries, but especially in hospice, because, nursing is a female dominated field. We're very empathetic creatures by nature. And especially in hospice, because our patients are going through such a change in their life. This is such an important time. And it's very, it's completely different than anything else. So we like to give them our full attention. And, that can, I think, weigh heavy on a lot of nurses who already feel that need to be overly empathetic and present. And, it's almost like not really a guilt trip, but I would say a lot of people in hospice do get almost addicted to the job because of the fact that they love what they do so much. So I feel like it's important to set those boundaries and say, you know what, my phone's going to go off after 5. I'm going to need triage to handle whatever comes up after I sign out for the day. I'm not going to do any other. And if, work doesn't get done, I don't feel that should be put on the case manager, because the fact that obviously there wasn't enough time in the day to do everything that they needed to do, and I'm honest about it. And I work on the days, usually I try to work extra when she's at her dad's. So then I have a little bit of wiggle room. But like, say you're trying to go get your kids, or you have to come home and be there to relieve the sitter at a time. That can be stressful for a lot of people if a visit runs over.
Mhm.
So I wish there was more of a safety net. I know we have it. We run kind of almost like a hospital. We have nurses who specifically work 4 to 12, like a group. And it's almost a skeleton crew sometimes. Depends on people who call out, and you all know that thing. But sometimes we're able to say, and I wasn't able to do that, or they can reschedule their visits. We also have case managers who work 4 days a week. They work 10-hour days, 4 days a week, instead of, so they get one more day, because I know, I need to babysit on that day, or I have this on that day. They want one more extra day of the week to themselves. So I think doing things like that, and learning your boundaries, like I said, shutting off your phone or not answering emails until like 10 o'clock at night. It's very, very important. Physical health is super important, but like, to me, that's like eating my favorite food. Or like, if I'm exhausted from a day's work, I'm like, I'm not going to cook dinner today. I'm going to get takeout. Like, people will be like, don't eat so unhealthy, it's bad for you. I'm like, I take my daily vitamin. It's fine. It's better for my mental health if I don't have to go through the rigmarole of cooking and then having to clean the dishes some days, if I truly had a mentally or physically exhausting day. Because some days are more mentally, but you have more mental fatigue than you do have physical fatigue, because your brain just had to work through so much stuff. And a lot of hospice is emotional, and it weighs heavy on your shoulders sometimes, because you think about what the people you're interacting with. I look at a lot of my patients, and I think of all the patients I've seen over the past 6 years I've been in hospice, and none of them are with us today. And you think about those numbers, and you think about all the lives that you've been a part of for that small blip. You knew these people, you knew their families, you've been inside their homes, you've shaken their hands, you've given them hugs, you've held them, and you've seen them at their last moments take their breath sometimes. And it really, sometimes when you think of that, and it hits you at the most random times, and the other night, I think it was a couple of weeks ago, I started crying because I started thinking about this one patient, and I was like, what the heck is going on? All of a sudden but sometimes you just need to cry. And we don't cry in front of the patients. I don't cry in driveways. I don't, it's not my moment to be comforted. It's not. not about me. It's not about any of us. It's about that patient and their family at that moment. And we have to be that rock. So if we want to take time to ourselves to grieve, it's normal. We can turn to our chaplains if we need to. They have a lot of great coping skills. I know for a lot of our pediatric patients, I've only been a part of I've only seen like 2 peds patients since I've been working because it just doesn't come up. We have a whole team for pediatrics that are on call 24/7. We have specific nurses who are hospice pediatric nurses. I mean, I can't even imagine. I don't think I could do it that much, but I think grieving in your own way is important as long as you don't stay in that moment for too long. You know, people say grief never ends. It just ebbs and flows, like the amount that you feel. You know, some days you might feel sadder than the other, but I don't think the grieving process truly, I don't think there's those stages of grieving like we're all taught. I think grieving can be a lifelong thing. You can always grieve the loss of a loved one, but it does get easier some days. And some days it might be a little bit harder. And that's how we look at it with our patients. You know, at least I do. Some days I look at them and I know they're comfortable. I know they're safe. I worry more about the families than I do about the patients because they're left with that void, right? They lost the patriarch or the matriarch or that staple of their family, you know. And that is the hardest because then they're the ones grieving. The patients, they're okay. They went home. They got taken home. They're good. I'm like, they're home now. And that's what we do. It's just hospice is the process of just walking them home at their own pace. Whenever they're ready, they get called home. And, you know, it's not like what you see in the hospital. It's not traumatic. It's like a candle in the wind. I have to literally stare at people sometimes like this. I'm like, are you there? Still, it's like a candle in the wind. And I have to listen for that minute. And I know they're okay now. And they're going to be okay. The ones I usually worry about is the people left, the families, the kids, you know, especially the kids. The kids usually take the passing the hardest, you know, and it's just, you have to take that time as a nurse to grieve yourself because a lot of us get close to our patients, especially case managers, because they're the ones in the aides too. They're the ones seeing these patients day in and day out.
Yeah.
You know, and we can see the bonds that they create and we're in their homes, we're in their lives. They become like a little part of our family and they treat us like family too. Like, do you want some of this? Do you want a cup of coffee? Drive safe. Make sure you drive safe. It's crazy on the road. I'm like, okay.
She loves
They're so
me.
sweet. I had one patient, she used to be a music teacher. So we used to sing while I did her wound care. And it was amazing. And she used to sing goodbye, Allison. It's like little blips of your patients that stay with you for so long. You can hear their voices, you know, exactly like their softness of, you know, their voice and the little things that made you laugh about them. And those are the things that I try to carry when I feel a little bit sad. I'm like, the good things are always so much better. I know that one day, like when I go to heaven, or wherever it is next, because I know I take care of a lot of variety of spiritual beings, as I like to call them. And everybody has their own version of what kind of comes next. And it's interesting because before people pass, everybody sees somebody or they feel somebody or, you know, so we're going somewhere. But since everyone believes in a different afterlife, I'm like, which one is it? You know what I mean? Where are we? It's great. It sounds fantastic because people see somebody, you know, and I 100% know there are pets there, 100%, because people see their pets all the time who have passed away. I had one lady, she passed away a week after her dog. And she's like, so-and-so is here.
So, I love the themes around death. I love the stories, the like pre-death moments, experiences, exercises, activities that happen. Oh my gosh, the patterns, it mirrors life.
Yeah. And they have their rally day. So like, I know a lot of hospice nurses experience this. We have the talk with the family, they're transitioning, you know, usually, you know, time sensitive, blah, blah, blah. And then the patient rallies and they're like, you were wrong.
Yeah.
I'm like, sometimes we are wrong because especially with our Alzheimer's patients, they're like this. They can seem like they're transitioning one day and we'll be like, this is gotta be it this time. This is the third time they're transitioning. They're like, oh no. And I
Back
see
for
her
a couple
sit,
weeks.
Alzheimer's is a roller coaster. When
Oh.
I say it's a long goodbye, because it truly is the longest goodbye, because you see this person from who they were going into almost a shell, but they
Yeah.
stay in that shell for such a prolonged period of time. If I have to find another job because we have to lose half of our patient population, and that means Alzheimer's gets cured, I will
Mhm.
find another job. I have no problem with that.
Mhm.
Any day,
That would
any
be
day.
great. Oh.
But like, you
Oh.
know what? I love hospice. We get to spend time with our patients. And, you know, I know at bedside, well, the true bedside hospital, you guys try as much as you can, but it's like,
We
it's
love that.
impossible.
Yeah, it's
It's the
impossible.
best part. But
And we're
we
on
are
the
literally
computer.
like one patient at a time to one patient to one, you know, and it's not that we're not rushed or we're not busy enough. It's just that in that moment, the patient is, that's it. They're our focus. They're the star of the show. I don't have to worry about going to pass meds to another patient. I don't have to worry about an antibiotic that needs to be hung or a drip running out.
Well, Allie, thank you so much for your time. I got a bunch of questions answered in just that. I got to like brief Allie at the bedside, Allie, the hospice nurse. Like I could feel it coming through, and I love that you love your work, and I can tell. And
I love it. Oh
I feel
God, I
so
love it so much.
comfortable.
I've met so many cool people, so many, and I know like we all do, but like because of HIPAA, like I can't be like, you know what, this person invented this. Like I meet
Yeah.
a lot of people who change our lives, but
Yeah.
are like, they're behind the scenes, so we don't know their names. And like, I've met a lot of World War II guys. Like how many people can say that they've met that many people who have been in, like, I feel it's so cool. These guys are the coolest people in the world. And like, they're all, I mean, amazing. I've met a lot of fabulous ladies. One lady was like, she got her degree in biology, and back in that time it was like a big deal to get a bachelor's as a woman, never mind biology.
Science.
Yeah.
It's a big deal. I've met nurses. I can't even tell you about us. Like when I say some of them are the best patients, they're probably the best patients. It's when the family members are the nurses sometimes.
Oh no.
Yeah.
I always say
Except
we're the
that-
worst.
Who aren't nurses but think that they are.
You nailed it. Yeah. I would have to say I have had a lovely time with patients who are nurses, and most of the nurses who are family members. It's the ones who come in from like out of state, and you know what I mean? I'm like, where have you been?
Banging the boss drum. Like I know. We're
Or medics who aren't the healthcare proxy, you know, their
Yeah,
family,
they're
they're
not the
concerned. I understand. I'm like, but we aren't the same. Like, I know what you're trying to do, and I understand what they're taught is completely different than what we are taught. Like, I get it. You're driven emergency medicine. You know a lot of stuff that I would have no idea on what the hell to do. You can put an airway in. I cannot do that, nor would I want to. But I'm like, sometimes they can be tough cookies because they're used to working in such a tough environment versus we're like hand holding,
Yeah.
you know, like,
Yeah,
I'm like, do you want me to massage your hands? One thing I like to do is when I go into facilities, I take the hair out of my patients' brushes. That doesn't get attention enough. I'm like, I hate hair. I hate loose hair in general. It makes me want to vomit. But if I see it in my patient's brush, I'm going to wash the brush and take out the hair. I'm like, those are the little things. Like, if you don't think about, like, I had one of our aides my patient, she dyed her hair for her. She was unable to do it herself, and she hated roots, hated it. Our aide dyed her hair. She went out and she bought her favorite foods because she didn't like the food at the facility either. And she got dyed and dyed her hair.
That's awesome.
When I tell you, we know our patients and we see them as, because we know we're like I said, this is why hospice can become dangerously addicting, because we're in their life for this small blurb, and we want them to feel like they're the star of the show, because that's what it is. Imagine you just found out you have only 6 months to live. You would want that
you get to dye your
specialized
hair. Yeah.
Shave your armpits, shave the mustache. I don't even care. Like, I will, whatever you got. Just let me, if you want to put on a full face of makeup every day, we'll put on a full face of makeup every day. You want to eat cheesecake? eat your cheesecake. I don't care if you're a diabetic, eat the cheesecake. If you want to smoke a cigarette and you're on for lung cancer, don't do it on oxygen, please.
Right.
But go
Safety
ahead and
first.
have the cigarette. We're basically not going to say no unless it puts them in like a really dangerous situation, because it's like, why does it matter at that point?
Mhm.
It
The
doesn't.
goals.
I love
goals.
it. That's why I love it. It's the goal. Our goals are different. We're not about like, how are we going to fix you? We're like, this is quality care, for whatever quantity of life we have left. And it's you know what I mean? It's a little bit different. And that's why I like it. Cause we can kind of like, well, they're on hospice. Oh, okay.
Right. You get away with a lot more in
Yeah.
the name of the patient.
In the name of the
In the name
patient.
of the job.
Exactly. Yeah. I'm
Mhm.
like, they want this. I'm like, you know what? Cause I remember you have patients who are at the hospital, they're NPO because of swallowing issues, because they're going to aspirate. I'm like, what we do is we explain to the family the risks,
Mhm.
you know what I mean? And then we kind of guide them as to what foods may and may not be better, like cheesecake, key lime pie, shakes, things like that, that are thickening stuff. And we explain the risks of what may or may not happen, but they're on hospice. Are we going to deprive food? No, not their favorite. Just give them a little taste, see how it goes. You know what I mean? When when people are like, they're not themselves, I'm like, you know what? They don't feel like, just cook something that is their favorite food, because sometimes that olfactory sense triggers.
Yeah.
And it'll make them salivate and maybe want them to at least taste their favorite. It's all about that moment, savoring that moment of them being taken back to their favorite food, or that favorite food brings them back to their time in their life. We're playing music that brings them back to their favorite time in life, looking through pictures, things like that. Anything to relive and, memorialize and kind of, just have them relish what is left of life and remember all the good things, because chemo can change a lot with patients' taste too. And they don't love any of the same things they do anymore. I'm like, well, try cooking something. Try to stay away from super strong stuff. Like, we don't want like onions. Sometimes that can make people nauseous, but like savory things, people love the desserts. Ice cream, huge. This is my next pitch. Ensure, but make it ice cream. High caloric, high protein ice cream, because I'm like, that's what they need, especially Alzheimer's patients who are losing that ability to even chew sometimes. The ice cream will melt, right? And the problem comes when they lose the ability to remember to properly swallow. That's when we run into the issues. But anything to bring them back, anything. I will try anything to literally make them smile for a second. It's a tough to figure it out, because some of these patients are not, most of them I say are accepting of their diagnosis if they're fully aware, but you do, I think every once in a while have somebody who's really not happy with the fact that there's not anything else that can be done. And I'm like, well, who says that you have, I'm like, you don't really have to, I wouldn't say you don't have to be on hospice. We have palliative care too. Palliative is another side that our patients sometimes transition over from palliative to hospice. Palliative, you can still continue with maybe an aggressive treatment, but they'll manage your psychosocial, emotional, and pain, which is huge. A team specializing in pain management for people who are going through any sort of aggressive treatment is huge. I think people associate like hospice, we're going to manage all your symptoms, including pain. That's one of our goals. We want to make sure you're comfortable. It's comfort care. But if you want to have that same level of control, you can always have a palliative care consultant. Maybe if you don't want to, if you're not terminal yet, or if you're not diagnosed as terminal with a 6-month or less prognosis, palliative can be a helpful hand, another tool in your basket. They also have medical social workers. They have a lot of the same tools that we have in hospice. It's just the goal of care is different. You're still looking for a curative treatment, and you're still driven to have aggressive treatment, and that's okay. If you're not okay with your diagnosis, or your prognosis, it's all about the patient and what their goal is at the end of this. We just want to make sure they're comfortable and they're freaking happy. That's huge.
Yeah. Thank you, Allie. Thank you for bringing us into your world for a little bit and sharing about it.
Thanks for asking. I love it. I love what I do. And I feel like it's such a hidden gem of nursing. And, I wish there was more ways for people to get in, because it's like, it's hard in a lot of places because they want X amount of experience. And like I said, nursing school isn't that experience.
Yeah.
So people are always like, I'm a new grad and I want to go into hospice really bad. I'm like, try applying per diem, because then you can just kind of get a feel for the ropes and you have something on the books.
Yeah.
At least
have a
if you
little
want to
bit.
apply, you have a little bit of, and you can learn at your own pace, essentially. Pick up shifts as you go. And if you're hesitant about it, you can try it out. And, sometimes people realize in training, like it happened a lot in prison. People would last like 24 hours.
Because it's intense, and it's not something that you can test out, and it's not something that you get any behind the scenes in any other capacity. You don't get to just go visit and like shadow for a while. That's a good last tip. Try per diem
And see if, I always say reach out and see if, or Google and like hospice nurse residency programs, because that's your tip to go and shadow and you get trained. And for us in my agency, I believe it's 6 months. So you get like a long residency. Our training is a month.
Wow. That's cool.
Yeah.
Well, we're going to put your links in our description so folks can find you and watch you on Instagram and TikTok.
My YouTube, I do for new hospice nurses. I do a lot of like charting, verbiage, because the verbiage we use is different too. Like words like actively dying, things like that you don't normally use when you're in, a curative environment.
Yeah, that's super helpful.
Yeah, so I do a lot of that and I think it helps families too, because the verbiage we use sometimes is like, what? You got to put it into layman's terms, but it can be big, bold, and scary for a lot of people. Hearing even some of the medications. I feel like educating is the best way to go about to learn that hospice isn't the stigma that people think it is. Like, we're not Dr. Kevorkian. We're not looking to do that. We just want to help you live your best life for however long you have left. That's it.
So good. Well, thank you, Allie, and everyone who's listening. Be sure to follow, because this is good. This is juicy. This is great information. I love the behind the scenes, and that hopefully will help others feel like they have a little bit of another stepping stone to get into the profession and around the profession, because I think this is some of the best parts of nursing.
Yeah, it is. It's a one-on-one patient. It's that care that we were taught to kind of take the time in, and the basis, like when I say make nursing good again, it's bringing it back to the part where we used to be able to do a lot of the hand holding and patient care, like the psychosocial emotional care that nursing is the foundation of, not just passing meds and calling physicians and things like, we need to get back to the good part of nursing, where we loved being a part of people's lives and changing them in that way, so that they remember not only you hanging that IV bag, but you also talking to them at midnight about an issue, or something, taking a little bit of time. Nurses in the hospital don't have that time anymore. Sucks.
That's the epitome of putting the human back in medicine. Like this really, it just encompasses everything that medicine was founded to be. Not what we currently have in the hospital system, at least.
That's why I love it.
Well, thank you so much, Allie. We'll talk to you soon, and we'll see you on social media.
Thank you so much.
Thanks, y'all, for listening to the Pulse Check podcast. We'll see you next time. Bye.